recorded, and I've started the recording now. My name is Julie Alonzo, and I'm the Program and Communications Coordinator at the Safe States Alliance. Today's webinar is brought to you by the University of North Carolina at Chapel Hill Injury Prevention Research Center, the Southeastern and Southwestern Injury Prevention Network, and the Safe States Alliance. We thank you for joining us. During today's webinar, you will be introduced to the Injury Policy Opportunities Project, which is designed to provide an understanding of the changing landscape of opioid overdose, the rise of this public health epidemic, the current burden, and the different governmental, nonprofit, and advocacy groups involved in this complex issue. Through this series, participants will learn effective strategies for preventing and reducing opioid overdoses. As a reminder, to ensure a successful webinar experience for everyone, please be sure to mute your line, close out of unmuted programs for the duration of the presentation to ensure you have a good connection. Should you have technical issues during the presentation, I will be available to assist. Please just send a message or use the raise hand feature in your GoToWebinar taskbar. And finally, please note that the presentation is being recorded and will be made available. I will now introduce our moderator for this webinar, Jennifer Woody, the coordinator of the Southeastern and Southwestern Injury Prevention Network. Jennifer, can you hear us?
I can. Can you hear me?
We can hear you.
Fantastic. Thanks, Julie. Good afternoon, everyone, and welcome to the webinar, the kickoff of the training known as the Injury Policies Opportunity Project, or Ipop, from here on out. The focus of this training is on prescription drug overdose, and it's designed to give you skills to identify, educate, and evaluate policies that can help prevent overdose death. Next slide, please, Julie. So unlike usual webinars where you just kind of get on and that's the end of it after you hang up, this is a really exciting opportunity because this is just the beginning of a training that is available that will culminate in an in-person training in next spring. But just so everyone has the basic of how this works, we are having 2 webinars. This is the first one that are open to anyone that's interested in learning more about overdose prevention. If you're interested in going further into this topic, we have an application process, and you see a address up on your screen, and my colleague Eva is going to put that web address into the chat box so that you all can copy and paste it if you need it. And the application is there. The full information about what we're doing is there. The folks that apply and are selected to participate will then go into another webinar that's closed only to the registered participants, and then the training I mentioned in the spring. Next slide, please, Julie. So we're really excited that the faculty that will be offering the training in the spring and the January webinar that will get the folks that are involved in the project more acclimated to what you're going to be doing at the in-person training are Carolyn Crump and Jim Emory. Some of you may have experienced trainings with these folks before, but they are just fantastic, have tons and tons of experience in public health and policy and getting folks organized to really make a significant public health difference. So this is just a little bit about Carolyn and Jim. Next slide, please. So one of the questions we've been getting is who should think about coming to this? So we definitely are interested in having people who are working in state health departments on this issue come. But as most of you know, policy issues cannot be tackled by just one agency, and it's always important to have a coalition of partners working on something. So we really encourage folks to bring together multi-agency or multidisciplinary teams to come to the training. Up to 4 people are able to be on a team. Next slide, please. So just a quick overview of how what I said just summed up here with the dates. We're here today, October 17th, and that is the webinar number 1. Please be sure to register for our second webinar, also open to the public on November 16th. So the first webinar today, we're going to be getting kind of the background of what this issue is all about. The next webinar is going to get more into what are people doing about it, and we're excited to have Ohio and Kentucky are able to share some stories of successful policies that they were able to put into place. And then for those who want to go further, the early bird application is due the 30th of November, and there's a discount for folks who want to do that. Final deadline to apply is December 9th, and then you see those dates for the private webinar and the in-person training in Chapel Hill. Excuse me. Next slide, please. So this is just an overview of what the cost for the training is. You can see that, again, all this information is on our website, so don't feel like you have to feverishly write anything down. Next slide, please. And so we always get this question that, will this webinar be recorded? Yes, it absolutely will. So if you're interested in this training or you're not interested in this training and you just want to share this with your partners or anybody that you're working with who may not understand what this issue is all about, this particular webinar is going to be a great thing to share with folks. So the link to review this recording will be sent out to folks who are registered today. We'll also put it on the Ipop website. Next slide, please. So I believe that is maybe all my slides. I think it is. So, oh, sign me up. Again, this is just the end. Another plug, please go ahead and check out the website. All the registration forms, all the dates, everything that you need to know is on our website. So without any further ado, we will get on to the good stuff, the content from Joann, who is the lead for policy and partnerships in the Division of Unintentional Injury Prevention, which sits within the CDC's National Center for Injury Prevention and Control. In this capacity, Joann oversees partnership engagement and policy activities as related to the public health issues that fall within the division's purview. Prior to joining CDC, Joann practiced as a public interest lawyer and also worked as a policy analyst and lobbyist on children's health issues for a Georgia-based nonprofit child policy and advocacy organization. Joann received her JD from Emory University School of Law. So we're so glad to have her here today, and with that, I will turn it over to her.
Thanks, Jennifer, and hi, everyone. I'm Joann Kang, and first of all, let me begin by saying extending thanks to everyone who's associated with Ipop for giving the invitation for CDC to participate in today's conversation. I think that when we were getting started in some of the earlier conversations about the Ipop initiative, I was so pleased to hear about just how comprehensive of a program it is, and also the fact that opioid overdose prevention activities was the specific focus. Very clearly, this is an issue that is causing great harm and is a tragic reality for individuals and families and communities throughout the United States. And so I'm very pleased to share in just a little bit of an overview of what CDC is doing. And of course, as has been already mentioned on the webinar, we are just part of the solution. And so for those of you who are joining in the conversation today, we thank you for being a part of the solution, and I look forward to the discussion. Before I get started, I will just say that any of the views and opinions that are noted throughout today's conversation should be construed as my own and not anything attributable to CDC as an agency. And with that, this next slide just gives you a little bit of an overview for where I am housed, my colleagues and I are housed within the Division of Unintentional Injury Prevention and some of the other focus areas that fall within the purview of our division. As has been mentioned, the Division of Unintentional Injury Prevention is one of 3 divisions that falls within CDC's National Center for Injury Prevention and Control, which in turn is one of 12 centers throughout the agency as a whole. And in this slide, I just wanted to orient you to some of the other topics that are covered within our particular division: motor vehicle safety, falls prevention among older adults, and traumatic brain injury, recognizing that, of course, there are some cross-cutting features across the different topics. And the other thing that I wanted to note is that this slide may be a little bit outdated because it specifically says prescription drug overdose, but within recent months, we've been speaking more broadly about our prevention activities for overdose prevention among opioids, given the troubling rise of heroin-related deaths and also those deaths related to other illicit opioids, including fentanyl. I'm not going to spend too much time on this slide, but I wanted to give a little bit of background in terms of the public health model. And so here on the slide, you can see some of the underpinnings for how we at CDC are approaching this topic as well as others. As CDC is the nation's public health agency, of course, we are very tirelessly working to identify and work to address and prevent those primary causes for mortality and morbidity for Americans across the U.S. And so this is just a little bit of a preview in terms of our thinking. So in speaking with Jennifer and other colleagues in terms of the type of information that would be helpful, I think for purposes of this first webinar to really set the groundwork for what we are seeing, the suggestion was made to give a little bit of an overview with regard to the changing landscape of prescription drug overdose and the rise of this particular epidemic. And given the fact that this is definitely one of CDC's expertise in terms of the epidemiological and scientific expertise that is housed here within our agency, I wanted to go through a few slides just to highlight the ways in which CDC has been tracking the issue. We've been doing this for over a decade now, and it was really in the early 2000s when CDC epidemiologists started taking a closer look at some of the data when they noticed a substantial increase in the number of deaths among adults from unintentional poisoning. And in one of the first articles that CDC published on this emerging issue, there was a 2006 analysis that looked at the dramatic increase in poisoning mortality rates and compared it to the sales of opioid analgesics nationwide. And so this is going to be highlighted in another slide. But before I go into some of the specific data, one thing that I thought would be interesting to point out is in November of 2015, there was a perspective piece that was actually written by Dr. Courtwright, who is a historian at University of North Florida. It was published in the New England Journal of Medicine, and what it was depicting was the history of preventing and treating narcotic addiction in the United States. Dr. Courtwright was detailing within his perspective piece about how around the turn of the previous century, so in the late 1800s and early 1900s, the U.S. was experiencing a sharply rising narcotic consumption, which sparked a reform response. He described how physicians at that time were using morphine injections to treat pain, and that really a lot of this activity was the most important driver of what he deemed to be the addiction epidemic of the 1870s and the 1880s. And the reason why I wanted to point this out is because this isn't necessarily a novel epidemic or a novel issue, but it's something that the United States has experienced before. And while I don't think that that is a rationale for doom and gloom, one thing that I do want to point out that Dr. Courtwright had said in his publication is that history offers grounds for optimism, and that insofar as earlier self-education and self-reform movements measurably slowed what he deemed to be the addiction epidemic, there also is the opportunity now. And so what we want to do is use the best data and scientific analysis available so that once again we can stem the epidemic as it's rearing its ugly head in our present day. So the next few slides that I'm going to be showing are all courtesy of Dr. Leonard Palazzi, who is a colleague of mine here at CDC. For any of you who have conducted research on this issue, you likely are familiar with Len and his great work. And what I think is so fascinating is that Len was an epidemiologist who was really focused on motor vehicle-related mortality and morbidity. But as he was taking a look at the data, he started to notice that the data were indicating a troubling rise of overdose deaths. And so that's really when CDC began taking a closer look and tracking this epidemic. And so here in this slide, you'll see a breakdown of the unintentional drug poisoning mortalities rates by drugs in the United States between 1979 and 1998. And as we're looking at some of the national data, what CDC found at the time was that a lot of these concerns were really being affirmed by what states were experiencing on the grounds. And so there are a couple of notations that are made on this slide. In Maine Medical Examiner report from 2002 found a rising problem with prescription drug abuse. And in what is called an epi-aid or an epidemiological assistance, states can request specific assistance from scientists from CDC to be on the grounds to assist with any kind of a public health crisis that they may be facing. And so there was an epi that was conducted in the state of North Carolina in 2002 that found that prescription narcotics accounted for 90% of the increase in drug deaths between 1997 and 2001. And then the last bullet on the slide is just showing some of the data and the new mechanisms that were used, looking at ICD-10 coding in particular, to find that prescription opioid deaths were outnumbering heroin deaths during 1999 and 2000. CDC's involvement in this issue began roughly around 2004, and because I know that the discussion about the different data systems at play is something that would be helpful for today's conversation, I just wanted to make note of some of the data sources used back then, which again are used today as well. And so those include mortality data from the National Vital Statistics System, drug sales data that's housed by our colleagues at the Drug Enforcement Administration, and of course data sets from our colleagues at SAMHSA. I mentioned earlier one of the first publications by CDC in 2006, and this is really when we started to sound the alarm on the epidemic related to opioid overdose mortality. And so here you have a couple of the details that are included within one of the first publications by CDC on this issue. And yet again, confirmation by what we were seeing within the state. So in the next few slides, I'm going to be showing a little bit of information and analyses based on more present-day data. The first of which is depicted on this slide, is that the amount of opioid prescriptions dispensed in the U.S. has quadrupled between 1999 and 2014, but the amount of pain that Americans report remains unchanged. And of course, this is of particular interest and concern given the fact that opioids are commonly prescribed for the treatment of chronic pain among patients. And in this slide, we see that unfortunately overdose deaths have increased in lockstep with prescribing increases. And since 1999, there have been more than 165,000 deaths from overdoses related to prescription opioids. And I think that a lot of times when we talk about numbers this big, it's a little bit easy to lose focus on the individuals. But I think that one of the virtues of CDC as an agency being involved in this work is that we have heard from family members who have lost loved ones, but also, and optimistically, we've received correspondence from individuals who had been suffering from overdose addiction on their own, and which was eventually overcome. And so I think that this is something that I wanted to put a finer point on, because I think at CDC, a lot of times we talk about the large numbers, but don't go into the details about the individuals and the families who are affected by it. So in this slide, you see the lockstep increases in the sales of opioids along with the increase in deaths. And in this next slide, you will see it depicted in a somewhat different manner. As prescribing patterns vary greatly by state, so do the overdose deaths. And so this displays the amount of opioids sold in each state according to the yellow dots, whose size correspond to the amount of sales, while the colors of the states correspond to the overdose death rate for each of those states. And so as you can see, the states with more opioid pain medication sales tend to have more drug overdose deaths. And I know I mentioned it before, but I wanted to give pause because I think that there, of course, is the rising concern of illicit opioids, so heroin as well as formulations of fentanyl and its analogs. And so on this slide, based on the data that I believe is out of our colleagues at SAMHSA, 3 out of 4 people who used heroin in the past year misused opioids first, and 7 out of 10 people who used heroin in the past year also misused opioids in the past year. So I think that this helps to depict some sense of the nexus that exists between prescription opioids and illicit opioids as well. And on this slide, you see the increasing rates that's really cut across the different types of opioids. And so you have the commonly prescribed opioids, heroin, methadone, and the synthetic opioids such as fentanyl. So if I stop the presentation here, I know that it would be entirely sobering and not getting us to where we need to go. And so I'm so pleased to be able to share some of the great work that's underway. And in doing so, it's not only the work of CDC as an agency, but as Jennifer had stated, it really is a multi-sector and a multifaceted issue that needs a multifaceted approach. And so we are just one of many agencies, partners at the federal, state, and local level who are working to tackle this issue. So one of the things that we always strive to do, CDC as an agency, is really capitalize on our particular niche and work in conjunction with our other federal colleagues. And so I think that opioid overdose prevention is such a great topic for today's conversation because there has been such wide buy-in. I think that there has been a recognition that's shared among so many that there is a need for us to work very quickly and effectively to reduce the death toll, and as well as a lot of the morbidity that's happening across the country. I think this is something that is shared at all different levels of government and organizations, from federal, state, and also down to the community and city level. And the other thing that I wanted to mention is that it's also something that's really taking hold across all three branches of the federal government. And so one of the things that I wanted to highlight was, of course, the fact that President Obama and his administration has really signaled that opioid prevention is one of the main topics of importance for his administration. Within Congress, we have seen so much leadership that's shown, because I think that given the reality of how this is striking communities across the country, it really has been a bicameral, bipartisan issue where we have seen support from so many members of Congress. And in addition, with regard to the judicial branch, I think it's really interesting the ways in which drug courts have been engaged as well, looking not only at how best to address the criminal activity that is involved, but also how we can prevent them from happening in the first place, and also saving lives. And so with regard to how the administration is working to tackling this issue, hopefully all of you, or many of you, are aware of Secretary Burwell's opioid initiative that really has three prongs: providing training and educational resources to assist health professionals in making informed prescribing decisions. The second, which is increasing the use of naloxone, which is a drug that can reverse an overdose and help to prevent mortality. And the third is expanding the use of medication-assisted treatment. And so, of course, CDC and our federal partners, many of whom fall within the purview of the Department of Health and Human Services, are all undergoing activities in alignment with the Secretary's three-pronged approach. That said, as I mentioned earlier, what we always want to do is maximize our expertise and our niche, working to capitalize on what we do well as an agency, strengthening collaborative efforts across with our federal partners, and really working to avoid any kind of duplication of efforts. And so as we at CDC were struggling for how do we wrap our arms around this epidemic and what can we as an agency do, we came up with what we call our three pillars for CDC's work in this regard. And it's, for lack of a better term, maybe the guardrails that we use, the parameters through which we really want to focus in on those activities and those efforts that are really within CDC's purview. And so the three that are listed here are to improve data quality and track trends, to strengthen state efforts by scaling up effective public health interventions, and to supply healthcare providers with resources to improve patient safety. And I'm going to be doing a quick walkthrough of each of the three. So one of the questions, again, that was raised was for us to talk about the ways in which we can capitalize on available data sources to take a closer look at this epidemic. And so I know that Ohio is going to be one of the presenters later on in the webinar series, so I'm not going to go into too much detail here. But in 2015, scientists from CDC were on the ground in Ohio in response to a request that were received by that state for an EPI-aid to assist with addressing the alarming outbreak of illicit opioid-involved deaths that the state had been experiencing. And in the request letter that the Ohio Department of Health sent to CDC, they identified that they had reported 502 fentanyl-related unintentional overdose deaths for Ohio citizens in 2014, which constituted a 500% increase from 2013 rates, with fentanyl-related deaths accounting for 20% of all drug poisoning deaths that year. So of course, this is a staggering issue that Ohio is facing, and if you've heard a lot of the news, some are calling Ohio the epicenter for the heroin and the illicit opioid outbreak, which I think is just heartbreaking. So when we were on the ground in Ohio, one of the things that we worked very quickly to do was to partner with epidemiologists within the state to use multiple data sources for comprehensive analysis. And so these are vital statistics data, coroner and medical examiner reports, and toxicology reports. One of the things that our scientists utilized was looking at the National Violent Death Reporting System, which is a reporting system that is that was created by colleagues here at CDC within the Division of Violence Prevention. The other data sources included looking at the state prescription drug monitoring programs, or PDMPs, the Emergency Department Chief Complaint and Triage Notes for more comprehensive information about what had happened related to the overdoses, emergency medical services data, including when EMS professionals had administered naloxone, and also DEA data on heroin and fentanyl drug seizures. This graph, I think, is just staggering, and it overlays law enforcement seizures in dark blue and fentanyl-involved overdoses in light blue in Ohio. And so this is the analysis that was derived from the work that our scientists had done. And so when you look at how closely those are being tracked, you see that really what the issue is within our states and communities. Other means through which we're working to improve tracking and monitoring is, of course, capitalizing on prescription drug monitoring programs. And I'll be going into a little bit more detail about how this is being operationalized through our state programs. But basically, PDMPs contain critical clinical data that helps to identify patients at risk for opioid-related overdoses, to inform providers of other medications the patient is receiving that may interact with those prescribed, and to help to identify patients struggling with substance use disorder in order to make a referral and get them the treatment and services that are needed. Basically, when we talk about PDMPs, I think that they are such an effective public health surveillance tool as well as a clinical decision support tool. So the second of the three pillars is strengthening state efforts. And one of the things that I want to show, and really this is in response to what I had mentioned, was the strong congressional support for this work. Here on the bottom axis, you can see the number of states that CDC was able to directly fund throughout fiscal years 2013 through currently in fiscal year 2016. So there are 0 states in 2013. In fiscal year 2014, we were able to pilot what we were calling a prevention boost program, giving a modest investment to 5 states who were really at the intersection of a high drug overdose burden and who demonstrated the readiness to be able to take and run with effective interventions. This work was scaled up through increased appropriations that CDC had received in fiscal year 2015. And currently in 2016, with yet again another increase received from members of Congress, we are now able to fund 44 states and Washington, D.C. across what we're calling our overdose prevention in states efforts. So when we talk about the prevention in states effort, we're really talking about 3 component programs. The first of which is the Prevention for States program, which currently is funding 29 states, and I'm very pleased to say that North Carolina is one of them. And when we were scaling out the activities that we wanted for states to implement, we were really wanting to have states enhance and maximize the use of their PDMPs, to implement community insurance health system interventions, to conduct policy evaluations of policies that had been implemented within the state to address the opioid epidemic. And the fourth component, which was not required, but we call Rapid Response Project, which gives states the ability to be a little bit nimble and propose projects in order to quickly respond to the overdose epidemic as it's manifesting within their borders. Building upon that, with additional funding that was received, just in August of this year, we were able to launch the Data-Driven Prevention Initiative, where we're funding an additional 14 states. When we were going toward more states, one of the things that we recognize is not all states are at the same point of readiness for those who may have competed successfully for earlier funding. And so it really was derived as a 2-tiered approach, funding states so that they could apply for either planning and data component alone, which is really to shore up a lot of their infrastructural capacity, or to apply for both planning and data activities as well as prevention and action activities, which track very closely with the 4 key strategies that are noted above for the PFS program. In fiscal year 2016, CDC was also appropriated funds specifically to look at heroin and other illicit opioids. And with that funding, we launched the Enhanced State Surveillance of Opioid-Involved Morbidity and Mortality, FOA. We are funding 12 states to monitor illicit opioid abuse risk factors, and to improve the timeliness and quality of opioid overdose data across the board. It really is our hope that the improved quality and timeliness of surveillance data will help to support and inform efforts not only at the state level but nationally as well. So with regard to the last of the three prongs about equipping providers with resources and tools, I think that the biggest accomplishment within the past year is the release of the CDC guidelines for prescribing opioids for chronic pain, which was released in March of 2016. The purpose of the guideline is to provide recommendations for the prescribing of opioid pain medications for patients 18 and older in outpatient primary care settings, and it really focuses on the use of opioids in treating chronic pain. And here what you see is an overview of some of the premises behind the guideline. My assumption is that many of you may already be familiar with it, and so I'm not going to go into too much detail, but basically you see depicted on the slide some of the rationale for why CDC engaged in this work, and an overview of how we see providers as key stakeholders and working along with public health and other stakeholders to reverse the epidemic. One of the later slides is going to include a link that will take you to where the guideline is housed on our website, along with other tools and resources. But basically, one of the things that I wanted to highlight before we go toward the discussion is some of the work that's underway through our agency in terms of guideline implementation. Because despite the fact of so much work that went into development of the guideline, we didn't want for it to be a document that sits on the shelf. So very quickly, in conjunction with the release of the guideline, we started pivoting toward our implementation strategy. And here on this slide, you see kind of the 4 quadrants of activities that loosely provide the quadrants in which a lot of our implementation activities fit. So we see translation and communication, clinical training, health system implementation, and insurer and pharmacy benefit manager implementation strategies as well. One of the earliest activities for implementation were a series of tools and materials that were released in conjunction with the guideline in March of 2016. And so in this slide, you see some of the materials that were developed and are already posted online, including graphics and messages geared toward patients, fact sheets, posters, podcasts, and infographics. In addition, we also have, before I move on to training resources, I did want to mention some of the materials that are related to physicians. And so my apologies for not including this in one of the slides, but I think one of the great tools that's available on our website is what we're calling the provider checklist. And so as we were finalizing the 12 recommendation statements that comprise the CDC guideline overall, we worked with the Atul Gawande's group to come up with a clinical algorithm of sorts that could really operationalize the full gamut of the recommendations into step-by-step processes that a provider could walk through. And so that's just one of the tools that's available on our website. In addition, there are other tools that are forthcoming. I believe that just today we have released, and I think it's now available on our website, but there is a pharmacy brochure recognizing again that pharmacists are a key stakeholder, and when we talk about providers, it's not just clinicians or physicians, but we're talking about a broader group of provider stakeholders that can work together to reverse the epidemic. So that is one of the newest tools that's been released by our agency. And another one that's forthcoming is a mobile app. 2 of the components that will be comprised in the mobile app are a morphine milligram equivalent calculator, so that physicians and pharmacists as well can see how to calculate morphine milligram equivalents across some of the most commonly prescribed opioids. And another component of the mobile app is tips for providers on how to engage in what may be difficult conversations with their patients. And so there's some recommendations using motivational interview tips. And now moving on to this slide, in terms of training resources, there are a couple of things that I wanted to note. The first of which is that CDC, I believe it was in August or perhaps earlier on, launched the beginning of a 7-part webinar series looking at how to, again, break down the recommendations of the guideline into easily identifiable, distillable recommendations for providers that they can implement within their clinical realm. And so the first of the series was an overview of the guideline overall, and then in the topics that are depicted on this slide for webinars 2 through 4, what we wanted to do was to make these trainings as interactive as possible. And so we partnered with colleagues at the University of Washington, where there was a didactic portion where there was a little bit more information that was shared about one or more of the recommendations contained in the guideline. And then there were case examples that were presented, giving those who are on the webinars an opportunity to engage in conversation and dialogue as well. And so if you weren't able to participate in the first 4, they are archived on our website. And I believe that the remaining 3 of the 7 are going to be released in November and December. And if I'm remembering correctly, the last 3 topics will include risk mitigation strategies, medication-assisted therapy, as well as, again, honing in on tools and resources providers and pharmacists as well to have those difficult conversations with their patients. One of the other quadrants for implementation activities is with regard to health system. And so on this slide, you'll see some of the ways in which we're working to operationalize the recommendations within health systems. A clinical quality improvement initiative has been launched to help health systems develop guideline concordant quality improvement processes and to facilitate implementation of some of the recommendations. And so basically where we are right now as an agency is refining QI measures through stakeholder engagement, creating an implementation guide, and then launching, supporting, and evaluating this QI initiative within a number of hospital systems. We're also working to embed a lot of these recommendations within EHR systems because one of the things that we recognize is that providers often have so much to do while they're sitting there with a patient and with regard to treatment of their patients. And so we want to facilitate as much ease as possible. And so to the extent that a lot of the recommendations can be streamlined within EHR and HIT processes, that's one of the things that we're looking to maximize. Another opportunity is with regard to the coordinated care plan for safer practice. And this was work that was initiated actually before the development of the CDC guideline. But CDC is implementing and evaluating a coordinated care plan informed by group health program, which incorporates recommendations for health system operations such as identifying a champion, using EHRs, checking PDMPs, creating data dashboards, monitoring and creating a feedback loop for clinicians, and also includes clinical content when that component will be closely aligned with the guideline since it has subsequently been released. And again, a lot of the health system efforts can also be incorporated through our funded states. And I'm not going to go into too much detail because I know that some of these activities and successes are going to be shared in future webinars. And on this slide, you can see some of the insurer interventions that we set forth when we're having conversations both with public insurers, and of course that includes our colleagues at the Centers for Medicare and Medicaid Services, as well as private insurers and other groups with which we have had conversations subsequent to the release of the guideline. And so some of the interventions that are listed here include coverage for non-pharmacologic therapies. And I think that this is something that's underscored in recommendation number 1 of our guideline, because when we say that opioids should not be considered the first line of treatment for chronic pain management, of course that means that there is a need to increase access to those non-opioid as well as non-pharmacologic therapies. The second is to improve the ease of prescribing non-opioid pain medications. The third is reimbursement for patient counseling, care coordination, and checking of PDMP. So really incentivizing those practices that we think would enhance a provider's ability to care for patients with chronic pain. The fourth is to promote more judicious use of high dosages of opioids outside of palliative care, active cancer, or end-of-life care, using mechanisms such as drug utilization-related strategies. And the last one is to remove barriers to evidence-based treatment of opioid use disorders, such as eliminating lifetime limits on buprenorphine, which is often used for MAT treatment. And just to go back to one of the things that I mentioned earlier, we do not do this work in a vacuum because we advance. The epidemic is so large and so multifaceted that we are contingent upon the successes of our federal partners and all of you at the state and local level to really work with us in advancing the efforts moving forward. And so listed on the site and on this slide are some of the partners, many of whom I had already mentioned, so our federal agencies, and of course law enforcement and DEA. I think that this has become even more necessary given the rise of heroin as well as illicit opioid-related mortality. Medical and pharmacy associations and academic institutions. One of the things that I didn't mention earlier, but I think would be helpful to share for purposes of this call, is that after the release of the guideline in late March of this year, I believe, the White House had released a press release in which there were 60 medical schools who had made a voluntary commitment to embed some aspect of CDC's guideline within their 2016 curricula. And so, of course, we have definitely been appreciative of that voluntary commitment made and have been in conversations with the groups that are represented within that 60 to see what kind of tools and resources we can provide to help with those efforts, much of which have been embedded within the webinar, the 7-part webinar series that I mentioned earlier. In addition, of course, are the insurers and the health systems, because they are the venues in which the interventions have to be implemented, partner organizations, and this just spans the gamut. And of course, I would be remiss in not mentioning the strong partnership of states and local health departments. And with that, let me just conclude by saying thank you. That was a whole lot of information, and hopefully all of you can join into the discussion at this point.
All right, well, thank you so much, Joann. That was exactly what I was hoping to hear, and it was really informative to see all the places that you all are working and to find out kind of how it all fits together. So thank you so much. So as we mentioned, we have a chat box where we'd love it if you all could type in your questions. But in the meantime, we have a question from Alan Della Penna, who is working as a panelist, so he can't show it to everyone, so I will read it to you. So his question is, PDMPs are a promising tool to combat this epidemic. They're still new systems. Is there any effort to develop performance standards and measures of effectiveness for PDMPs?
Sure, thanks for that question. I think that there are a couple of things that I can make mention of, and so one of which is in conjunction with a partnership that we have with Brandeis University, which is the PDSS. And so I think that through Brandeis' Center of Excellence, the PDMP Center of Excellence, I think that they're a great resource that's available. And one of the things that we've been working with them on is looking at the information, the de-identified information that come in from several different PDMPs. And I think that it does several things. I think that it gives us some indication of promising tactics that can be applied, as well as some of the evaluative components in terms of the information that gets fed in. In addition to that, I think that some of the opportunities are those that are outlined within our state program. And so I would say that through our overdose prevention and states efforts, when we talk about maximizing and enhancing the use of PDMPs, it's about more timely reporting, about universality in terms of the collection of the data, and then the proactive reporting, making sure that the information is not just coming in, but then it's also going out. In addition to that, and one of the things that I wanted to echo from before is the extent to which PDMPs can be linked to other health systems that are operating within the state, the better their efficacy. And so I know that certain states that are funded by CDC are looking at means for linkages to other data systems, including hospital data, including state Medicaid data, and other EHR systems, because I think that that just gives a better access, a more comprehensive picture of what's going on, and an ability to look across. One of the things that I will say is that I know that Van Ingram from Kentucky is going to be speaking on the next webinar, I believe, and I know Kentucky has done a lot of innovative approaches in really enhancing their PDMP system, likewise with Ohio. And I would say that this is likely a good question to also tee up for Corey Davis, and something that I'm assuming that he will be mentioning as well. Corey is, of course, a trusted partner and a great partner to CDC, and I know that looking specifically at PDMPs across the 50 states and how they're, or 49 states, and how they're operating is part of his realm of expertise. And so I'll kind of stop there because I don't want to be repetitive of anything that's going to be mentioned at the next webinar, and I do think that they are likely better poised with their expertise to speak on that.
Okay. Thank you. That's very helpful. We do have another question. This is also from Alan in North Carolina. We have done a lot of work to implement Good Samaritan laws at the state level to increase access to naloxone. Oops, hold on, I got bumped. Is there an effort at the federal level to work with FDA to reclassify naloxone as an over-the-counter drug? That would make our work so much easier at the state level and save a lot of lives.
I am not familiar of that. That's not to say that it's not happening, but I'm happy to ask some of my colleagues here. And I guess on that point, Jennifer, I'm happy to, any specific questions where I don't have the specific answers, I can route to you, and I'm happy to do that follow-up. I know that outside of some of the efforts at the federal level in terms of the FDA realm, I know that there are states and even communities that are taking efforts in terms of trying to make the availability of naloxone more widespread. So whether it is a standing prescription of sorts that allows for individuals to be able to gain access to naloxone as a potential bystander who can reverse an overdose. That's one example that I know of offhand. I know that I believe it's the city of Baltimore and other efforts are underway in communities and throughout. Some of the other activities that I'm aware of that are not necessarily at the federal level, but through individual entities, maybe some of the interventions that are being implemented by like Walgreens, for example. I know that there's so many different individuals and venues in which they're trying to increase naloxone, and so I would say that those are some of the strategies that I can point to. But in terms of the specific question about FDA efforts, I don't know offhand, but I'm happy to follow up.
Okay, great. I know that that maybe is something that lots of folks are interested in. And actually, so yeah, just so folks know that if there are things that come up as questions that you have when we no longer have access to Joann on the webinar, you can contact me, Jennifer Woody, and or Eva Bland via the Ipop website. I think both of our contact information is up there, and we can route your questions to Joann. So we actually did have a question come up. This is from Chandra Daniel. What are the specific data measurements that could be requested from the law enforcement and the DEA?
I think that there are several. So one of the things is with regard to the drug seizure rates, and just going back to that slide that I had shown in response to the Ohio Epi-8, I think that what you could see is that there was the close tracking of where there were seizures and where there were overdoses. And to the extent to which we may have early access to some of the data in terms of where they're seeing hotspots, I think that that could be a really helpful public health tool in terms of how best to anticipate perhaps where there may be issues and work very quickly in terms of prevention strategies. One of the things that I wanted to mention is that with the need for closer partnerships between CDC and DEA, or law enforcement and public health more broadly, there is a recent activity that I think is really innovative, which we are doing a personnel sharing agreement. So we have a scientist from CDC who has just recently moved up to DC over the course, within the last few weeks, and will be there over a course of a year, and we're anticipating the same to happen for somebody from DEA to be housed here at CDC. And I think that this is really going to be a key means for us to do a lot of the information sharing, to streamline a lot of the data access issues that could cause hiccups otherwise, and to really increase our respective understanding of the data systems that are at play. I know that one of the other types of data that has been helpful is with regard to even pricing, right? So the data that they have available in terms of pricing of illicit opioids and how that may increase access, I think is something that can be indicative of where you may see outbreaks. In addition to that, all of the data that they have available in terms of heroin, fentanyl, and some of the new analogs, I think is crucial. And so, we have been working in lockstep with them. Another initiative that is housed under the Office of the National Drug Control Policy, or under Director Botticelli, is what are called HIDAs, and that's high-intensity drug trafficking areas, in which you have a multi-sector response that is really geared toward a geographic area with law enforcement, public health, and other interested stakeholders who are working collaboratively to address and better depict through data what's happening within those regions. And so more information on the HIDAs, I believe, is housed under ONDCP's website, and so I would definitely recommend that you visit that website for more information.
Okay, great. Yeah, I think it's always great to point us to additional resources. I know CDC has so much great stuff online, and depending on kind of where you're trying to find it, it can be helpful just to get the best place right away to go to, because there's a lot of stuff to sift through. So we have another question. This is from Steve Marshall. Does the CDC have suggestions for best practices in introducing this topic to others and raising awareness of this problem among our non-PDO community partners? For example, when I'm interacting with clinicians, other than pain doctors, I often say things like, we need to talk about pain and pain management rather than let's talk about overdose. So what other kinds of ways are there, the CDC thinking about how we can introduce this to people who maybe aren't quite as immersed in it?
Sure, I think that's a great question, and hello to you, Steve. I think when we talk about it more broadly and in a variety of audiences, one of the things that we discuss is that there are really dual public health issues. And so one is the issue of chronic pain that is a reality for so many Americans. The other is the mortality that's attributable to opioid overdoses, and the fact that there really is a nexus across them between the two. And so I think that it is always effective to start the conversation by talking more broadly about chronic pain management, because then you can really start to tee up the conversation about some of the other strategies instead of a just don't do this. It's really, are there other treatment options who have benefits and may have a decreased risk versus implementation or prescribing of opioids for a particular patient. I think in terms of how to make the case, I think what we have found as an agency is that a lot of times decision makers and partners at the state and local level are coming proactively to us because they are hearing from their constituents. I think this is particularly true of members of Congress. And so in terms of highlighting this particular issue, the extent to which you can personalize it is something that, of course, is always a way to bring a greater level of reality of the tragedy of this particular issue. And sadly, you don't have to look far. I think on a day-to-day basis, we are made aware of different stories of children who have lost their parents and vice versa to this epidemic. From a public health perspective, I think that one of the things that we always aim to do is put it into the broader context. And so on one of the early slides, you saw that this is really just one of 4 priority topics that are handled here. So I think the extent to which we can show how this is an issue that falls within the broader realm of a public health issue and crisis, the more receptive it may be for somebody who may not normally think of it in that perspective.
Gotcha.
I don't know if that answers the question or if I can clarify.
I think those are definitely some good things to think about. And you know, I know that not one size will fit all for whatever situation, but I think that was some good outline of kind of which direction to head. We do have only about 3 minutes left, and we have 2 more questions. So I think these can somewhat be combined together. We have one from Wendy Stephen that is asking about the place of our nation's poison control centers in these efforts, and she's asking whether there is a place that the poison control hotline information can be posted kind of nationally for the public to see that. And then another question we had was around whether naloxone, the use and administration of naloxone is being trained for folks that are in law enforcement and first responders. And I guess I see those as related because they're both kind of in response to someone who's already had an overdose. So there's the question about training for first responders and law enforcement, and then how are the poison control centers involved in these efforts?
Sure, I can start with the second one. In terms of training, I know that a lot of that is happening, and it falls largely outside of CDC's purview, and so I would definitely defer to the expertise of our colleagues at SAMHSA, since it's more within their realm. In addition to that, I would say that NHTSA as another agency is engaged in this just because of EMS officials, or EMS personnel and professionals, and they fall within under the purview of NHTSA. I know that DEA is likewise involved for their law enforcement officials, and I think especially when they are talking about overdoses that may be attributable to some of the very potent illicit opioids, there is some very specific information in terms of administration of naloxone that I think would differ with regard to whether it is administered through an intramuscular formulation or the nasal, because I think there are differences that could be applied there. So I think that that's a little bit of the efforts that we're aware of, but again, work that really falls more so outside of CDC's purview in terms of conducting the training itself, although we are working in conjunction with some of our federal partners on some analyses, and I believe an evaluation on some of the trainings underway through SAMHSA. With the poison control centers, I think that's the more nuanced question. I know that we have had some conversations with our colleagues here, but in terms of that as a source, I think that there could be some difficulties there. I say this not being fully aware of how the poison control hotline operates or the specifics that are there. I think that in terms of the data sources that we use, it's more along the lines of the toxicology reports as well as some of the medical examiner reports. That's more so from the realm of any deaths that are attributable to opioids, and in terms of morbidity, it's more so along the lines of ER data and EMS data. So I know that it's a topic that has been addressed internally here within the agency, just given the work of some of our colleagues who are situated elsewhere in the agency, but I think that there are some nuances in terms of the data that are captured and perhaps how they can be characterized, but I'm happy to do some follow-up as well on that one.
Okay, great. Well, thank you so much for that. I think we will end the question period now, and I just want to say thank you so much, Joann, for a fantastic webinar. I would love to have more time to kind of pick your brain, because this is such a huge topic, and you know, there's so many different places, and it seems like you have luckily been exposed to many of them, and that it's so great to like have you as a resource. So again, we will, if applicable, channel questions over to you if folks come up with stuff after the webinar is over. And I did just want to finally remind everyone that we would love it if you want to sign up for the full Ipop project. As you can see, you're going to learn lots of fantastic stuff, and you know, you can't really place a value on the in-person training that we're going to be able to offer you in April of 2017 through the project. So we really encourage you to go to the website, which is up on your screen right now, and check out the registration form and the due date. The early bird is November 30th, the final is December 9th, and really hope that some of you can attend either individually or as teams. So I want to thank the Safe States Alliance, the UNC Injury Prevention Research Center, and of course the CDC and Joann again. And with that, we can disconnect. Thanks, everyone.
Thank you.
Thank you. Bye-bye.